Delighted to welcome our three panelists here today. Maureen Smith is a member of the HDRN Canada Public Advisory Council. Maureen has a long history of collaboration with the healthcare system. She has brought the patient and citizen perspective to various national and international groups on topics such as research ethics, rare disease policy, and involvement in clinical trials. Our second panelist is Stephanie Sinclair. She is an Anishinaabe woman from Sandy Bay First Nation. She is a mother of two children and the daughter of a residential school survivor. Stephanie works at the First Nations Health and Social Secretariat as a data sovereignty coordinator. And Hani Al-Ubeady is a member of the HDRN Canada Public Advisory Council with extensive experience working with diverse populations in Manitoba and has served the settlement and integration sector for over 20 years. And I will be moderating our session today. My name is Nathan Nicol, and I am an executive member for the Health Data Research Network of Canada. Each of the panelists will provide a 5-minute overview of their perspectives on the uses of health data. There will then be an opportunity to ask questions of the panelists, either individually or to the whole panel. And so first, I'm going to hand it over to Maureen, who is joining us online. You have 5 minutes, and I will let you know when you have 1 minute remaining. Maureen.
Thank you very much. Bonjour tout le monde, c'est un plaisir d'être ici, vous présenter des perspectives des patients, des aidants et des familles sur les données de santé pour les gens atteints de maladies rares. And I'm just very proud to be here as a member of the rare disease patient community, as a patient and as a caregiver. My husband, who was diagnosed with an ultra rare cancer. We're just the rare family here. So next slide. I'm just going to show you there we go. I'm just going to show you very briefly a few facts about rare disease and then ask you the question, do you think that health data is important to the rare disease community? So here's our definition of a rare disease. So one person in 2000. So the least rare of rare diseases would be cystic fibrosis. And the most rare ones are ones where they may be the only case in the entire world. And we know that there are over 7,000 rare diseases, and that one in 10 Canadians will be affected by a rare disease. They're also often very catastrophic diseases. So 1 in 15 babies is born with rare disease, and nearly a third will die before the 5th birthday. And it takes on average 3 wrong diagnoses and 3.7 years to get to the right diagnosis. My diagnosis started at the age of 4. And I was diagnosed at the age of 8 after many misdiagnoses. Next slide. So what I did to prepare for the panel is I spoke to a rare disease patient, a parent who leads a rare disease patient group because her daughter has a rare disease, and a parent. And I've got a couple of important points that they gave me. So the first one is about navigating the healthcare system and how daunting that is, especially with a rare disease where the care is often fragmented, and having access to that clear and accurate health data can ensure better continuity of care and collaboration between providers. The second quote is really about the importance of administrative data, which you might think might not be apparent for rare diseases, but really that can capture the experience of having a rare disease. And that's very important that we understand those experiences. So we have this capacity to look closer at the questions that are often overlooked about the experience of having a rare disease. And finally, about how collecting real-world data that responds to the needs of patients and addresses what's actually important to them is of vital importance. Next slide. So I came up with my rare disease data top 5. And these are the things that I think, my opinion, are needed to improve the lives of individuals with rare diseases and their families. So number 1, huge interoperability, and I'm speaking to the right network for that. So for example, CADIS, the Canadian Drug and Technology Health Committee, encourages linking our registries to healthcare administrative data but we need to do it from across Canada and even internationally. And is it worthwhile for rare diseases to do that and go through all that work when we don't have the interoperability to get as much data as we can get? Now, my number 2 on the list is that what gets measured gets counted. So are we measuring what we can measure because it's straightforward? And is it important to patients? And who is determining what real world data is collected? My number 3 is really about data to improve care. And that care is based on what we learn from data from general populations, which often doesn't transfer to the care needs of rare disease patients. So, for example, a lot of complex care or where they navigate multiple providers. So through pooling of data, we've been able to determine, for example, that 1 in 10 Canadians have a rare disease. It's very important to move forward policies that are going to help people with rare diseases. So 1 in 12 Canadians have heart disease. Well, now we know that 1 in 10 have a rare disease, and it's really important statistics and that have been realized through improved practices in health data. Number 4 is really the importance of patient registries and of post-marketing data. So many interventions that we use in rare diseases are used off-label. We need that data for safety and for continued use. And we often go into decisions with limited evidence. So for example, when my husband was diagnosed with ampullary cancer, which is an ultra-rare cancer, we had to make decisions that were based on borrowed data from similar cancers. And I can tell you that's a pretty frightening thing to make a decision when you don't even have the data for your own type of cancer. And finally, individuals with rare diseases have concerns with privacy issues, dealing with impacts on their employment or on their education. It's a population that's easy to identify, and every effort must be made to protect our data so that it can't be used to harm us. And I'd like to finish with, next slide, I'd like to finish with a quote from a parent with a child with an ultra-rare disease who says that rare disease is incredibly lonely. Undiagnosed rare disease is like a black hole. Families often have no information on what to expect for their child, especially if, like us, their child is literally one of a kind. Our daughter has an ultra-rare gene mutation, and we currently don't know of another child in the whole world with our daughter's same mutation and symptoms. What gives us hope? Knowing that data is continually collected, cataloged, and submitted into databases around the world. Knowing that as technology changes and tests get more and more sophisticated, there's a chance that my daughter can meet someone like her, that as parents one day meet up another family that gets it in a way that no one else does, that maybe one day we may have some treatment options that will make a difference, and that perhaps another family like ours will get a diagnosis earlier and won't have to wait and wonder for so long. Knowledge is power, and the more we know and share, the more likely we are to find answers. And last slide, I just want to express my thanks and gratitude to Christine Dalglish, Catherine Stratton, and Christine White for their very valuable contributions to this presentation. I sent them each a note, and within 12 hours, the 3 of them had responded to me, and that's the strength of our rare disease community. And we want to collaborate with HDRN Canada to make sure that what is being shared is what we'd like to be shared, and that the interoperability part is always there. Thank you so much.
Thank you so much, Maureen. And just as a reminder, we're going to hold questions to the end of the presentations. So next we have Stephanie. Stephanie, so you have 5 minutes to share with us, and I'll signal you when you have about a minute left.
Okay,
thanks.
sounds good. So good afternoon, everyone. My name is Stephanie. I work at the First Nation Health and Social Secretariat. So we've been working on data sovereignty with the nations in Manitoba. So my organization works with the 63 communities in Manitoba, and it was established by the Assembly of Manitoba Chiefs to work on health and social issues. They established the Health Information Governance Committee in 1996. So that's when the first regional health survey was done in Manitoba and across Canada to address some of the gaps in data that exist, because the census didn't go on reserve. So this was our own kind of way looking at data and what we wanted to measure. In 2014 is when the First Nation Health and Social Secretariat was established, and basically all the people that worked in health at the Assembly of Manitoba Chiefs transferred into the new organization. And with this transfer, we also included what was approved by First Nation leadership up to that point in terms of data sovereignty, which is to uphold OCAP, ownership, control, access, and possession of data, to have free and prior informed consent at the individual and at the First Nation community level, to enact First Nations ethics. So when you're working with a community, it could be different if you're in one community over another, even if they're the same nation. So taking that into consideration when you're working within different communities, and that the research must benefit the First Nations. So it either has to be a question that they're interested in or have some benefit that they can use the information in the future. The goal of the data sovereignty work for First Nation is to have access, control, ownership, and possession over our own data, and have a center like this in each of the communities that can facilitate them using information and advance health and wellness in each community. So we're working on it right now at the regional level. We're providing supports to communities, tribal councils, treaty organizations, and political organizations to have use of First Nation data, to be leading research, and to create opportunities for next generation to learn and lead this work. So we're really looking at all the same things you guys were talking about today. Is the data accessible? Is it usable? Is it accurate? Does it reflect the values and needs of the communities? And one of the reasons why we find we really want to use health administrative data is that it shows that the gap is widening. So the last report that was done in collaboration with the Manitoba Centre for Health Policy shows that there's an 11-year gap in life expectancy from First Nations to non-First Nations in Manitoba. So that's one of the reasons why we really want to continue to use this work and broaden it. When you're working with partners and allies to develop relationships, they need to be based on, as we talked about here, trust, mutual respect, and decolonizing systems to address the ongoing impacts of colonization. So this includes doing research that's beneficial to communities and serving as an ally all the way through to addressing the results of the research. So not just putting the research out there and saying there's a difference in life expectancy, but not having any solutions of how to address this moving forward and what are some benefits or solutions that could go along with it. So I just wanted to share a little bit about my, one of the research projects I've been working on through COVID is looking at the impact of a birth help or an Indigenous doula on the health and well-being of First Nations mothers and babies. So we know that birth has been removed from communities and is now a medical intervention. So now we're looking at what is the impact. So when we started having these discussions with communities, they wanted to know how are we going to measure that impact, right? So the first step of our project was to develop our own nation-based indicators. So we worked with Cree and Blackfoot communities in Alberta to develop nation-based indicators so that they can measure wellness from their own ideas and what they want in the future. So, and what they had before. So they started by talking to different groups, including knowledge keepers in the language, to find out what were some of those concepts of health, and then working from there to how do we measure that. I think that's pretty much what I wanted to share. So it continues to be an honor and privilege to work with communities. And one of the other ways that we work within this project, we establish relationships through ceremonies and cross-cultural training. So we've been to each other's communities, to each other's ceremonies, and we have people that are hired directly in the community that are working to gather information. And we wouldn't have had a project during COVID if we didn't have those people in the community that were working. So like the first 2 years of the project, we never met them in person. So we worked all through Zoom and Teams and all kinds of ways. But that was one of the outcomes of the project, was that now we have these nation-based indicators and we're working to use them to see what comes out of some of the interventions that the communities have designed in order to improve their own health and wellness. So that's the kind of research that we want to eventually be able to link with administrative data so that we can show the outcomes in both ways. That's all I have.
Great. Thanks so much, Stephanie. Next, we have Hani, who's going to share just a little bit of his perspectives for health data as an ally. Hani.
Okay, excellent. Thank you. Good afternoon, everyone. I'm very excited to be here, but I also was searching in my mind thinking, this is such a big topic, and which angle should I kind of tackle? But to be specific and probably use the time in a useful manner, I would focus on very specific demographic, and in this case, the newcomer refugee or former refugee. It's a very specific group of people. Not every person comes to Canada under the immigration, I would say umbrella, would be a refugee. The majority of people arrive here are actually independent immigrants, and very small, tiny minorities are refugees or former refugees. And so why did I choose this is because I think there is very specific concerns around gathering information or identifying information when it comes to this specific group of people. Being a refugee, that means you have experienced some type of persecution under the 5 areas of persecutions that are identified under the immigration law, and we don't have time to identify all of them. But the purpose of me mentioning that is people who experience persecution or fear of persecution, they tend to hide some information or don't feel safe to share the information. And for that reason, you may not have a proper access to the actual information, and therefore appropriate service can be designed and delivered. So that's essential for people to know, and also to kind of keep that in mind. Do they actually lie, or there's another reason for them not to disclose such information? So fear plays a huge role, and it is actually an interesting component and very important component in terms of admission, to be admitted or at least recognized as a person in need for protection. So it's very interesting dynamic. It can work in one aspect, but it can affect another area of one's life. So that's in terms of, I'm hoping that I can cover those 4 points here. Each one needs a conference on its own, but I would say the other one is live interruption. And the live interruption is when a person seeking protection would end up in a place that is, we can call interrupted lifestyle. And that is where the person is actually seeking relocation or placing them in a safe place, such as Canada. So that interrupted stage plays a huge role in terms of information and the flow of information, but also the accuracy of the information. And then the language that we use to identify specific ethnic groups. And if I ask you here, without looking at my last name, to take a guess where the heck I came from, or at least what type of ethnicity I belong to, you may come up with a few answers instead of specific one. Lumping people under one specific ethnic group or region, it may not help for a specific reason, as we say here, data collection, data identification, and also use of data. So yes, it's very important to be specific, but also it's very important to use the specific and accurate language to describe every and each one of us when it comes to data. Let me see here. There is a specific story that very short. Do I have 2 seconds or minutes?
You have 2 minutes.
Okay, well, I have lots of time then. On my way coming here, I was listening to comedians, and some of the stand-up comedians, I can tell you, they have lots of wisdom. So, and this guy was saying when he went to, I think he went to the emergency room, and he was saying, he was asked, so describe your pain. And he goes, that's an interesting one. How do I describe my pain? Scale your pain from 1 to 10, 10 is being the highest. And now in his mind, he's saying, if I say 2, they may not take me in. He went in with number 10 or 11, whatever he chose. Well, guess what? The treatment was a little different. So he's trying to kind of change the information. And I'm thinking, that is interesting. So that's very active example of providing accurate information. And this guy thought he will get the right treatment based on whatever information or answer he gave, and not necessarily reflecting the truthful feeling that he's going through. But anyways, I find it very interesting that when it comes to capturing the right information and what people intend to do with their answers. Let me see, trust. The concept of trust, I heard it in the morning, I think, in the morning segment. So this is very much connected to the fear concept, trust. I have examples. I happen to be I work for Winnipeg Regional Health here as a cross-cultural mental health specialist. And it's very interesting to see the mental health component and the physical component coming together. And sometimes you say, okay, where do I stop? Is it mental health or is it medical care or physical care? Where I have 1 minute left? Good. Okay, so technically I have a case it's very interesting case where both exist in the same dynamic. Both the physical and the mental health came together. But guess what? There are boundaries. You cannot step. Those boundaries, you have to stop at where you're designed in terms of area of work. And in order for us to share information with other people, other professionals and others, confidentiality comes in. Now, confidentiality is very interesting concept. With specific culture groups, confidentiality plays a huge role in the form of barriers. So I'm not going to step out of my boundaries and go to the 6 minute. I'll stop here.
Yeah.
Thank you.
Thanks so much, Hani. Maybe we can get to it during some of the question and answer period. So we're at the point when we can engage in some dialogue with our panelists. I'm actually going to take the moderator's prerogative just a little bit because we've been talking a lot about how we ask questions. Earlier in the day, it was posed to us thinking about the for whom and with whom. And we were really challenged to be thinking about why are we collecting this information and what are we going to do with it. So with the broad conversation we've had today, I'm wondering if the three of you can comment on what can we do to ensure that the right data is being collected in order for the accurate stories with those data to be told. And I'm going to start with Stephanie to see if you have any thoughts or wisdom for us as a community.
I think the right data, if you want to check if the data is right, you have to have the context be understood of where the data was collected and how it was collected. Who it was collected from, who's inputting the data. So is that data firsthand or is that an observation? Like when we started to do a scan of looking at how First Nation people are identified in data, it can be done in a variety of different ways. So that's just one example, right? So if you want the most accurate, it would come from the people and they would have to be involved in the research.
Okay, thanks so much for that. Maureen online, I wonder if we could turn to you for your thoughts on that question.
Sure, thanks, Nathan. I hope you weren't signaling me when my time was up because I couldn't see you. So I hope that I wasn't, if you were, I wasn't ignoring you. I was just going on.
No worries, it all worked
I couldn't
out.
see you. Okay, all right. So basically stories humanize the data and they make it come to life. But it's how we create those stories, as Stephanie just said, that's what's important. So data can tell stories that are no longer viewed as anecdotal. If we look at the hierarchy of evidence, anecdotal is very low on that hierarchy. So for example, if you're collecting patient-reported experience measurement data, which is often also seen as a little lower on the data hierarchy than the patient-reported outcome measures, you can put together stories about people's journeys in their healthcare and their experiences that can have a tremendous impact on the outcomes and what we choose to present as a story of our condition. And just lastly, the operative word is correct, right? That was in your question. So as a patient, citizen advocate and research, the obvious answer is that the data that's important to patients, the caregivers, and the public, for rare diseases, by collecting the data, we need to collect the data that will answer the questions that are important to us. One of them is making our way through health technology assessment to get access to a drug. So we have to collect the data that decision makers want also, and also the data that will help us improve our quality of life. And so we can prove that when we're looking for improvements and our experiences with the healthcare system. Thank you.
Thanks so much, Maureen. And Hani, any thoughts or reflections on the question?
I think I will share the same understanding as Stephanie's when it comes to the cultural context, but also the, I think researchers and those who collect data, they need to take a step back and think, what is the group that targeting here? And what the cultural dynamic in terms of some cultural groups take very long time, the very specific answer that you're looking for. So you need to craft very specific conversations to get what you want. But also all of these elements that we mentioned earlier play a huge role in terms of shaping up the accuracy of the information. And so I think one would culturally trusted ambassadors to kind of go to specific communities so they can access information that is established based on established trust and relationship with the very same sources, in this case, in the targeted community. My voice is muffled. I'll blame it on luck in this case. Yeah, so I think that's probably nothing specific, but I would say, keep in mind, try to, I'll use those buzzwords, try to change your tools. And when it comes to collecting data or trying to harvest specific data, you have to kind of establish this trust and relationship with the very targeted group before you go on and be busy in terms of crafting your questions ahead of time. I would say do the pre-crafting of questions.
Thanks so much, Hani. So we also have about half an hour remaining for questions either online or here in person. So I see Louise coming up to the mic.
First, just a comment for Hani. I know you think that only newcomers lie in the emergency room. I've got news for you. We all lie in the emergency room. So I don't know what you can do with that information. But my question is mostly for Maureen, but obviously everybody else is jump in. Maureen, it's Louise. I haven't seen you for a while, so hello. I want to ask you about the difference between what we should be developing as a framework for real world evidence data, which is often qualitative, versus the kind of data that is collected in clinical trials, because we know that rare diseases often don't make it past phase 2 clinical trials because of the small numbers of people. So do we have a framework for collecting those qualitative data in a way that I know all about CADA as you do, would somehow work somewhere, and maybe maybe internationally somebody's got something going there?
Yeah, so Louise, as you know, we now have this rare disease drug strategy that has just starting to spend its money. And we are going to be having a big grant now to develop basically centers of excellence. And I was looking at a CADIS primer last night on real world evidence 101. And actually all of that administrative data is all part of that real world evidence too. We tend to think of it more as qualitative, but actually there's a lot of quantitative data in there too. So for me, it's really a matter of who's collecting it, what are they collecting? What's the value of it going to be to us? And do we have a say in what's important to us in collecting, so that we can show the impact of our disease and show the need for certain treatments and for certain policies that we need to improve the lives. So I know, like, globally, there's lots of work being done. It's a huge question now, and it's really relevant to the rare disease world, but you probably know more about that than I do. So I just think that it's just vital that we're not just collecting what clinicians or decision makers think that we should collect, that we're in there too, telling them what's important to us, but also keeping in mind that it's got to be a joint venture, because when we come to the table, we want to make sure that we've got all the evidence that we need to make a really strong case. kind of where I sit. I don't know if that's helpful, Louise.
I just want to clarify one thing, if you
Oh,
don't
sorry.
mind.
I'll just respond
Go
to
ahead,
it.
go ahead,
May I?
sorry.
Yes, it's very helpful. And the real question is, how do we get to the table as equal partners in these situations? And I hope through the rare disease framework, we're going to be able to do that. But you really need to, put your foot down. And of course, I'll be happy to give you a foot too, if that's helpful.
I agree. I'm with a research network called Inform Rare, and our work is co-produced and co-designed with patients. And I've been pretty vocal about when they set up whatever network they're going to set up, that the patient community has been very vocal about the fact that we should be sitting at that table. I think there's a strong possibility that it's going to happen, Louise.
Annie, did you want to say something?
Just probably clarifying by the trust, but also not telling accurate and the truthful information does not mean lying. In this case, what we mean is fear, the component of fear may not allow the person to actually disclose information, because in the first place, people are actually fearful, seeking protection, and therefore disclosing information may jeopardize the whole process of them gaining that protection. And so there's probably, I think there are a number of steps before it need to be taken place before asking questions or engaging specific group of people in a conversation or even a research interview.
Thanks. I wonder if we could turn online, see if there's any questions from our online audience. So for Stephanie, how can individuals and organizations involved in administrative health data use support or spearhead Indigenous data sovereignty initiatives?
I think by involving First Nation people or Indigenous people in the leadership of whatever research project you're doing is a supportive way in which you can support data sovereignty, and as well as providing the information back to communities or whoever you're engaging with in the format that they can use it. So not in a publication that's inaccessible unless you have a library or whatever, you're part of the university or academic institutions. But so for some of our projects, we did like one pagers that had the tables. They were in Word, so the community can cut and paste them into proposals, into information that they want to share within their community. So just some examples of how you could support data sovereignty.
Great, thanks. I'll also go to the second question online. And I think this could apply to all three of our panelists. How can authentic storytelling help emphasize the importance of interoperability of health data for public good? So I'm actually going to invite all of our panelists to reflect on that, but we'll start with Maureen for the question.
Yeah, I have a big problem in the healthcare world that we often speak in very abstract language. We're going to do this and the reason for this and the philosophy of this. What we need to emphasize the importance is actual case studies of how the interoperability of health data was used to make a difference in a community's life or in a person. In some cases, in rare disease, it could be a person's life. And we need those examples rather than just saying, oh, it's very important, we should do that. What is it exactly that it does? What is it about the health data and that will then increase the public good? So we want people to give their data, knowing that they're perhaps going to help someone else. But how do you know unless that's communicated back to you? And I think that's where authentic storytelling from case studies would give examples of how important it is. I mean, in my own life, I know from my personal experience, I was on a clinical trial that had 4 people on it. And we relied on all of the evidence from all around the world to figure that out. For my entire childhood, from the age of 8 to 18, I was on a trial of only 4 people. I was the only girl. So wow, that any kind of interoperability was very important for us, but also just the health data of just my interactions with the healthcare system, and how important that was, and how many hospitalizations do people need, and what case does that make for rare diseases? Because unfortunately, we still have to make a case for rare diseases because it affects a small amount of people. So we always have to make a case for why we should be improving the lives of those people. And I think it's in case studies.
Thanks so much, Maureen. Hani, I wonder if you could comment just a little bit about authentic storytelling and interoperability of health data, and maybe even like if you're like me and have trouble with that word interoperability, like how we're thinking about that within the context of this conversation.
Sure. I'll stay away from the bigger words.
Yeah, I do
And-
too.
And I'll stick to a very specific example. I'll share with you an example that actually took place and I was part of it. So there was a case that was handled by one of the clinicians that I know, and the clinician asked for my support with that specific case. And then he has very specific information as to what the case is all about, who's involved, and who's taken care of. But then once I got involved, and then situation took curve from mental health to physical, then we needed more information, and people got more people got involved. We realized that this very same person has family member that the clinician didn't even know exist. Not because the clinician didn't ask right questions, but it wasn't disclosed. And that piece of information, when it was disclosed, the clinician himself learned after a very long period of time, learned that this is a new, but that person played a huge role in terms of the health and the well-being of this very same individual in the question. So I think under authentic storytelling and all of that, I found out there's a huge piece of this story who was missing that contributed to the actually well-being of this individual who was suffering mentally and physically. So the mental health of that person was something, it's a longer process, but the physical one was urgent. And the urgency of the physical health or the physical aspect required more people to get involved. And as a result, we found out this piece of information. So that happened actually, and I was part of it. And the good thing is we found out the people that can help with that. So I think authentic stories, another story, which is really quick. With very little data that was available for a specific, very rare condition of 2 children came from Africa, that they needed cold environment. And guess where? They ended up here in Winnipeg, which is one of the coldest cities on earth. And luckily they are here. They could not stay in hot environment. And we knew that little about that case. But it was essential for many reasons. 1, you need to find proper housing. 2, equipped with AC because they arrived in summer. And then 3, you need this family their situation to be explained to professional and medical teams so they can provide the care that they need. As little as this, but it played a huge role.
Thanks. Stephanie, thoughts around storytelling with health data so that they can be used within the system or for the good of community?
Yeah, I think the health data, the administrative data doesn't collect a lot of information. That's just why we're developing our own nation-based indicators in order to tell the full story. But also within Manitoba, there's a lot of issues with interoperability, especially between federal and provincial and First Nation health data that doesn't speak to each other. So you can't really connect it in a meaningful way a lot of times to tell a whole story, which is something that we want to work towards. But we also want to make sure that the data is good before we try to repatriate and connect information in order to tell a whole story. But there is a lot of information that's missing, even when you look at all the databases, such as language,
Yeah.
connection to land, connection to ceremonies, just those types of things that we know what are connected to wellness and can improve health. So that would be some of the areas I think would want to work on together.
Yeah. Thanks for that.